So again, it's a pleasure to welcome you to this year's Taub Fellowship in Aging Project Symposium. I know everyone knows who I am, which is such a privilege. But my name is Dr. Lauren Snedeker. I'm a social worker. I'm also the Aging and Health Certificate program. I've worked with the Taub Fellows on their projects all year, so I'm very excited to share that with you all. And I'm an assistant professor at the School of Social Work. We have so many wonderful folks, including the dean, joining us this morning, which we're so excited. Um, the Taub Fellowship in Aging is a signature offering for Aging and Health Certificate program students interested in work with older adults, age inclusive practice, both through a clinical and macro lens. I want to thank the fellows for their dedication and efforts in leading this wonderful work all throughout the year at their practicum settings. They're going to be presenting shortly all of their hard work to you in just a moment. I want to thank also Julia Stumbos and the Taub Foundation for their support over the years of our students. Thank you, Julia. And the Taub Foundation for their support, as well as Dr. Emily Greenfield from the Hub for Aging Collaboration, Dean Leibowitz, and the rest of our social work family. And finally, thank you to the practicum instructors and agency partners who are here today as well for your collaboration as always and mentorship of our students and the next gen of social workers doing this wonderful work. So now I'd like to welcome Dean Leibowitz of the School of Social Work to join me in welcoming remarks. Thank you so much for being here with us this morning. And after this, our fellows will do their presentations. We'll have a Q&A, and Julia from the Taub Foundation will provide us with closing remarks. So thank you all so much. Dean Leibowitz, take it away.
Thank you so much, Dr. Snedeker, for that incredible warm introduction. Lauren, it's just terrific. The Hub is doing extraordinary work, and it's such a pleasure to be here to witness the impactful work of the fellows. And thank you so much for the invite to this. It's my pleasure to be here at this special gathering. And I just have to say, of course, if you let me, to tout the incredible work that's happening at the Hub as leaders in the field of age inclusivity and doing impactful work that is nationally visible and cutting edge research and so on. And also, shout out to MSW students in our program who are at the forefront of innovation as a result of this incredible sort of scaffolding. And we're so incredibly proud of them. Just, top of mind discussions around this is that when you think about the history of social work in general, the contributions of social workers are critical in the field of aging. And, those who care for older adults historically have not received the recognition to a large extent that they deserve. For years, if you think about gerontological social work or any work, clinical practice or programs and policies in MSW programs and so on, that hasn't really been at the forefront. And I just wanted to say the Hub is doing incredible work around that visibility. And indeed, you can argue that this work has been marginalized compared to other specialties. For example, child welfare or mental health is a few examples. But if you think about the current reality of shifting demographics, in which a growing number of Americans, for example, are entering the role of older adults and joining the ranks, and how we consider older adults these days as a shifting demographic, demands a radical shift in the way we think about our nation's priorities, to say the least. As the number of older people, particularly those over the age of 85, if you look for the research, Lauren and Emily, correct me if I'm missing this, is becoming more and more diverse compared to the demographics of yesteryear, and they need more assistance indeed to still remain active and independent. As people age, they have more and more complex healthcare needs, as all of us know in the room, with including financial difficulties, and they become less and less able to coordinate and increasingly manage those complex needs, hence the critical need of our profession. Social workers formulate care plans based on comprehensive assessments to manage interconnected physical, social, socioeconomic factors. I saw that these presentations today will highlight many of those things that indeed affect the health and well-being of older adults. So as social work begins to address the complex needs of the aging populations across settings, that includes, by the way, justice systems. We do have older adults in a variety of intersecting systems that require attention, and aging in place for those who consider doing the work in home-based services across the spectrum of increasing physical and psychological well-being is at the center of our work. Older adults maintain regular interactions with family, friends, and professionals demonstrated greater emotional resilience, and strengthening emotional relationships are really critical to our work. And that's where the heart of many of our social workers exist. Many of us indeed have become caregivers ourselves of older adults, myself included. And we know the strain and the stress and the beauty, I would say, and the amazing opportunity for that to be in to be in that space. So this annual symposium, which I'm delighted to be part of, will showcase this work of the Taub Fellows in Aging. Julia, I think I saw you in the room. It's echoing Lauren's wonderful remarks. You know, we are so indebted and appreciative of the work, of the contributions and support of Taub to help this work move critically forward. So, scientific excellence, thinking about collaboration across disciplines, the visibility of social work now compared to how I think to a large extent how as it used to be is really important to us. And we're delighted at Rutgers School of Social Work to be part of that innovation along with our amazing fellow colleagues and fellows here today. So thank you again for the invite. I look forward to these presentations and I'll pass it back to you, Lauren.
Thank you, Dean Leibowitz, so much. Thank you. All of your words just hit home. I've been in this role for 6 years. I'm so proud to work with the fellows and the Taub Fellowship and Julia and to have Dr. Greenfield's support in this work through the hub. And so I'm delighted. And I would like to now move us to our Taub Fellows and their presentations. They've all done it worked above and beyond the MSW competencies and thinking about needs and thinking about things that are occurring in practicum and in agencies and across the world, you know, and how we're working with older adults. And as I always say, if anyone has class with me, we're aging, we're living longer, and we're doing it with all of our stuff. So I'm going to go ahead and invite Peggy Chiappetta to begin our presentations. Our first fellow, you can take your time in just sharing your screen, and we're delighted to hear from you. Thank you all so much.
Wonderful. Thank you. Okay.
We see your slides.
Excellent. Fabulous. Thank you so much, Lauren. So my name is Peggy. I'm an MSW student, obviously, here at Rutgers. And this year I'm completing my practicum at Memorial Sloan Kettering Cancer Center. My project was focused on supporting oncology patients with age-related cognitive changes. And so here I'm using age-related cognitive changes to refer to more chronic progressive changes in cognition that are sometimes associated with aging, like dementia, or neurodegenerative conditions such as Parkinson's or Alzheimer's related cognitive decline, and which are distinct from more transient or situational cognitive changes that oncology patients might experience, like delirium, emotional distress, or treatment-related effects like chemobrain. Um, so I'll walk through the clinical problem that I observed and how I conceptualized it, and then the framework and tool that I developed in response. Okay. So at the start of the year, maybe a few weeks into my practicum, I was noticing a pretty consistent pattern across the outpatient services that I covered, but primarily in breast and GU medicine. We had a week where we had about 4 older adult patients present with subtle, emerging, or sometimes already diagnosed cognitive impairments or neurodegenerative conditions like Parkinson's-related dementia. But it wasn't always clear how to kind of interpret what we were seeing, and there was some distress among the interdisciplinary teams. And there was often kind of a sense of ambiguity regarding whether or not this was anxiety for the patient, is it overwhelm, or are we seeing cognitive changes? So the interdisciplinary teams were identifying concerns, but there wasn't really a shared framework or clear next step. And at cancer centers like MSK, we don't treat primary dementia or Parkinson's disease, we treat cancer. So what this creates is some variability across providers, depending on their experience, their training, and their familiarity with cognitive impairments. So I'll start with a very brief example. We encountered a 72-year-old patient who was newly diagnosed with advanced breast cancer. She was missing appointments, she was repeating questions, and her caregiver was reporting worsening memory. And so, using the framework that I'll introduce, this would fall into a moderate level of concern. So the response would include involving the caregiver referring the patient for further evaluation and consulting geriatrics. But the key question that also became quite central to my project was whether or not advanced care planning had been initiated and has a healthcare proxy been identified and documented. And so this matters because this is not a rare scenario. More than half of cancers occur in adults over age 65. Cognitive changes in these patients directly impacts treatment adherence, informed consent, patient safety, and advanced care planning. And these patients are also at an increased risk for delirium during treatment, and hospitalization. And the literature that I encountered shows that this is often quite underrecognized in oncology. And so this is where social work plays a critical role, I think, in that we are the ones who are best positioned to identify these concerns early. So one of the biggest challenges is that cognitive changes in older adults don't present clearly, right? They're often subtle, they're fluctuating, and they're highly context dependent. And so they can also look very similar to distress, emotional distress around their diagnosis, their prognosis, medication effects, or even what patients describe as chemo brain. And at the same time, there isn't really a standardized approach, at least in the outpatient social work at my practicum site, for identifying level of concern or determining intervention. And there's also a lack of clarity around when to involve caregivers and when to escalate concerns. And so the implications are significant. This obviously directly intersects with capacity, ethics, and whether care is aligned with patient preferences. So, in response to this, I approached this project in a few ways. So, I reviewed the literature on cancer care in patients with dementia and decision making. I consulted with outpatient social work, with geriatrics at MSK, and with ethics at MSK. And then also, I just reflected on what I was observing in practice, in supervision. And then what emerged was a need for a more structured, clinically grounded framework that was kind of paired with a quick reference tool that could be used in real time by outpatient social workers. So my final deliverable was a quick reference clinical practice guide, and the framework for this guide was focused on more on functional assessment rather than diagnosis. And I designed it to provide clear, actionable decision points while aligning with existing hospital systems like geriatrics, psychiatry, and ethics. And so the overall goal was really just to increase consistency, clarity, and confidence in how we respond to these patients, and these cases. So the framework itself is a very simple three-step approach. The first step being to identify red flags, the second being to assess and clarify, right? And the third being to determine the level of concern and response. And the key shift was really focusing on what the patient can functionally understand and do, rather than assigning a diagnosis. So this is step three, which was really the core of the framework that I created. And so at the mild level, you can see kind of intermittent confusion in terms of clinical indicators, right? But the patient might still be engaging with support. So the response is reinforcement, teach back and monitoring, right? And engaging geriatrics and beginning early conversations with the patient and their caregiver, if they have one, about advanced caregiving, advanced care planning, introducing the healthcare proxy. At the moderate level, confusion is typically more persistent across encounters. So patients might have difficulty retaining or applying information that they receive from the interdisciplinary teams. And at this step, we involve caregivers. Again, we refer for evaluation and we increase follow-up. At the high level, patients are quite clearly unable to demonstrate an understanding of their diagnosis, their treatment, their prognosis, and there may be safety concerns. And so this is obviously where we escalate to the team to ethics, and we prioritize safety planning. And at this level, obviously confirming and urgently establishing a healthcare proxy becomes essential, but this is something that should be introduced long before this level, if possible. So one of the most important insights from this project is the role of advanced care planning. Having a healthcare proxy is essential for all patients, but especially those with age-related cognitive changes. And so this needs to happen early rather than in a crisis situation. Social workers play a central role in initiating and normalizing these conversations with patients and their family members. But this is also kind of where it gets a little challenging, especially in my own experience as an intern, because patients often interpret these conversations as a signal that something bad is necessarily about to happen. So part of our role in social work is about reframing this as routine, proactive planning. And in my reference guide, I also offered like very simple language to use with patients and caregivers to kind of initiate these conversations. And then in social work, especially in the outpatient role, we're also assessing consistency over time, especially in terms of, designating a healthcare proxy. We're evaluating who the patient identifies as a decision maker and whether this remains stable across multiple conversations. So this framework is also designed to align with existing hospital systems. So at MSK specifically, geriatrics evaluates patients who are 75 and older using tools like the Montreal Cognitive Assessment, and they help to assess treatment tolerance and delirium risk. But they don't follow patients longitudinally, which is challenging and adds another challenging layer here. Psychiatry can support diagnostic clarification and conduct neuropsych evaluations, but again, these can be incredibly lengthy and taxing, especially for older adult patients. And then ethics becomes critical when there is uncertainty around capacity. There's conflict between the patient and the team, or the patient and caregivers, or there's no healthcare proxy in place. So part of this framework is to help social workers navigate when and how to involve each of these services. So in terms of response, there is an increased awareness that cognitive impairment is both a clinical and a systems issue. The feedback that I got was positive, and it really highlighted the clarity of the framework itself and the practicality of having this very quick reference guide. And it also pointed to the need for ongoing education and broader interdisciplinary integration. So there were a couple challenges. Firstly, navigating scope within a specialized oncology setting, right? One of the main challenges is working again within the scope of a cancer hospital like MSK, where we're treating cancer and not dementia. So a lot of what we're doing is recognizing and responding to cognitive concerns without actually managing the underlying condition. And this kind of creates a reliance on coordination across systems rather than direct intervention. The second being distinguishing cognitive impairment or changes from emotional distress, right? It's often very difficult to distinguish cognitive changes from emotional distress, medication side effects, as I said, or even chemo brain. And in practice, it's rarely immediately clear, which is why the framework emphasizes looking at patterns over time rather than making quick judgments. Addressing capacity without overstepping our role as outpatient social workers. This is, obviously another challenge, right? Social workers in this role are often the first to notice concerns, but we're not necessarily formalizing or formally assessing capacity. So then it becomes about identifying when something seems off and kind of facilitating further evaluation through psychiatry or ethics rather than making that determination ourselves. Another challenge that I encountered was, as I mentioned, the sensitivity of healthcare proxy conversations. Introducing a healthcare proxy in my experience over the course of the year has been difficult. As I said, patients might interpret it as a sign that something seriously wrong is happening or that they're dying. So it requires very careful framing as routine and proactive rather than reactive. And then finally, just time constraints in outpatient settings are a significant barrier. All of this is happening in a very fast outpatient setting where there's limited time to assess, revisit, and follow up. So the framework I found really had to be very practical and usable in real time. And then in terms of key takeaways, to summarize, age-related cognitive changes in oncology aren't just a medical issue, right? It's a clinical issue, it's systemic, and it's an ethical issue. Social workers play a key central role in identifying concerns and coordinating care, and then also supporting decision-making with the patient and the family. Early planning, especially around advanced care planning and identifying a healthcare proxy, is essential. And then finally, having a structured framework helps to reduce uncertainty and support patient-centered care. Thank you. And I'm happy to take questions as well.
Oh, thank you. Thank you. All of the applause emojis are coming up. Thank you so much, Peggy. I appreciate so much this work, especially at Sloan, and helping to encourage age-inclusive care, right, amongst all of our interdisciplinary team members and recognizing whether or not a diagnosis could be dementia, co-occurring with a cancer diagnosis, and understanding how we can prioritize the person in that experience throughout by knowing a little bit more about dementia-related illnesses and age-related changes to our cognition. So thank you so much for leading that. Gentle reminder, we'll take questions for all of our fellows at the end. But please feel free to put things in the chat and we can bookmark it. And now I'm going to go ahead and introduce Diana Grabel. We're going to be sharing slides for Diana, and thank you so much.
Hi, everybody. I'm Diana, and my project this year is Saging with Change, group therapy for older adults. I have a real passion for working with older adults, whether it's during a mental health crisis or navigating their end of life. And this year, my practicum was at Princeton House Behavioral Health, and that's a short-term inpatient mental health recovery program. And it consists of like voluntary, involuntary, there's a first responders unit, varying mental health conditions, and addiction and dual diagnosis and co-occurring disorders. So next slide. So I got the idea for my program because I first saw that Princeton House has a really excellent existing group therapy programs. And you can kind of read, I'm not going to read it word for word, but all the evidence-based practices. But what I did notice that no group was specifically dedicated to older adults, and that's one of the fastest growing populations in inpatient mental health settings. And what I witnessed is a lot of older adults facing these transitions like retirement, bereavement, role loss, stigma, feeling isolated, overwhelmed, underserved. That paired with a mental health diagnosis or addiction problems really worsened their symptoms. So I decided, oh, next slide. Okay, so I decided to research it and it did confirm the need. 1 in 4 adults 65 and over live with a mental health condition, especially anxiety or depression. Greater than 50% of adults with mental illness go without care. And I found that 8 of 9 studies confirm that group therapy does significantly reduce depression in older adults. So these life transitions, retirement, bereavement, health decline, compounded all the vulnerability. So group therapy tailored to older adults addresses the clinical and existential dimensions of recovery. I feel lucky that Princeton House embraced this project and really let me run with it. They were very accommodating, flexible, and gave great supervision and feedback during the process. Next. Okay, so I wanted to find a name that was really powerful. So I chose Saging with Change. Saging, being sage is someone who's obtained wisdom combined with aging. A little funny part, I worded it this way because when I combined it into one word, it kept autocorrecting to sagging with change. I said, oh, I guess that's an issue too, but we'll stay positive. So that name was chosen to empower, destigmatize, and center the voices of older adults as knowledge holders versus being needy people. Okay, next slide. Okay, and I had 3 core themes, and we had decided that since Princeton House is a short-term setting, I didn't want to focus on too much heavy topics because they are in mental health crisis, trying to get medications stabilized, getting sleep. So I didn't want to overdo death and grief work because that could be their next steps, when they go to longer term therapy. Um, so the three topics were resilience, social connection without pressure, and finding joy. And each session had a thick packet of resources, things like volunteer organizations, um, travel groups, recommended books and articles, anything that has to do with retirement or just transitions in life. And then each topic I had reflective and interactive exercises with discussion prompts, and we shared some excerpts of podcasts and videos. And then each of these decks contained some music videos from different eras and different cultures, like Elton John, Diana Ross, Shakira, just to try to make it a little fun. Okay, next slide. Okay, so how it was built, the design, like I said before, it's a short-term setting, so that makes it more of an open group type of setting because it's not the same people week after week. An hour long, once a week, and then sometimes I did do some a little more than once a week if that was if the time was available. And for the population, I went down to 50 years old and up because many patients are in their 50s and they seem to be going through very similar things. So I thought that was good. And it also it made it open to more people. And the facilitators were social workers or interns. And for the clinical methods, you can kind of read all these down here, but I used the most evidence-based methods to create these different programs and exercises. Okay, slide. All right. Yeah. Okay. And so the first session was resilience, wisdom grown through experience. And this in each of these, I had an interactive smart board. And for wisdom, we focused on resilience as wisdom integration. We did a little CBT, like reframing losses into how they can be looked at as gains or learning experience that contributed to our wisdom. We did a gratitude exploration. We took a nice short podcast by Jay Shetty and Trevor Noah. They seemed to like that. And that was helpful. And then we did a couple exercises, my strengths and resilience story and nurturing yourself, which were reflections with discussions at the end. And that really got the discussions going well. We talked about neuroplasticity and how your brain really never stops rewiring, and you can learn new skills at any age, whether you're 55, 75, or over 95. And emphasize that in older age, our brains can actually better connect with complex ideas and staying calm under pressure versus when we were younger. And an unexpected turn here was I was in the involuntary group for this one, and two younger patients asked to join. So we kind of try to keep it welcoming and open. So I said, oh, why not? And I really wasn't expecting, I thought I only had older adults, but they really brought a lot to the table. They brought some like energy, they were taking notes, they were all excited. And then the older adults kind of felt empowered to like share their wisdom. And that worked out well. So I decided to if that happened again in the future, that the younger people could join. Okay, next slide. All right, so the second session was creating your village, connection without pressure. So, we all know that isolation is a really concerning thing with older adults, but also a lot of people just really want to be alone and enjoy solitude. So we discussed balancing that and when to recognize when it's unhealthy type of isolation. And then we had an exercise where we kind of tiered the social engagement because a lot of people really, after these programs, they have a hard time acclimating back into their world afterwards. So we said, start out small, If you don't want to talk, just going to a park, somewhere easy where you don't have to talk, and then work your way up to maybe going to a coffee shop and asking simple questions like, what's on the menu today? And then the ultimate goal could be trying to feel a little more comfortable at bigger events like family reunions or networking events. Um, and so during our reflection, we kind of explored how can I spend more time in these green and yellow zones this week to feel comfortable and start with small wins. Um, and this was a really interesting, the memorable moments here was, uh, again, some younger people joined, and some of the older people, one guy in particular was saying how his kids were misreading his text, and there was a lot of conflict around texts. So then the younger ones were explaining certain things like if you end a sentence with dot, 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 that can have different implications that the older people had no idea what that meant. And then the older people were explaining the weight of their words. So it was like a nice exchange. And then an older person was saying, like, like even though I'm this age, I feel like I'm 20 years old in my brain. And then one of the younger guys was like, really? And it was just so interesting because they just got to understand that they have a lot more in common than people originally think. Okay, next slide. And the last topic was finding joy, living forward with joy. So with this one, I started out with a slide that had all these people that were 70 above, even up to 104-year-old skydiver, an 89-year-old woman who was world's oldest bodybuilder, the hidden figures person, all kinds. And so that was just to show people that you're never too old to kind of do some great things. Don't let it stop you. But at the same time, we wanted to stress that success is internal and you don't have to be famous and do really big things like that to have fulfillment, purpose, and meaning. It was just kind of meant to not feel like age has to stop you. Um, so we talked about some different things like hedonic well-being versus eudaimonic, and that's kind of like the simple pleasures, like smelling a rose versus pleasures from volunteering or mentoring. And that actually, as a side note, I used this topic for a dual diagnosis group at another time, and it was a good way to kind of like um, talk about addiction, like what would you do instead of using substances that would give you hedonic pleasure or eudaimonic well-being. And then we talked about the happiness trap, and that's the one where a lot of people think you should be happy all the time, but just showing people in the course of a day there's ups and downs like that, and that it, you just have to kind of recognize that, and that it's not going to feel perfect all the time. So then we talked about contentment over perfection, and if perfect is off the table, what is a good enough day like? We did an interesting joy mapping activity where it's a booklet and it shows a kind of an outline of a body, and they kind of think about like, where does joy show up in our bodies? What makes you feel playful, creative, and powerful? We did a grounding breathing practice, and that seemed to go over well for that one. So next slide. How the population responded. I feel like the older adults really felt validated. They felt seen. The unexpected reach was that it did really benefit the younger population as well, showing that these themes transcend age. And then honoring autonomy, because I did have one group where a few of the people were just not up for participating, but luckily I printed the packets and they wanted to take them back with them and just look at it on their own. And we always like, even if people are involuntary, they have a choice whether to join group or not. So this was a good way to be person-centered. And then, like I said before, the intergenerational exchange where the mixed ages turned out to be a really bridging and benefiting experience. Next slide. So what I navigated along the way, the challenges were from day to day, there's a fluctuating census of older adults and also just people coming and going. So you're not going to have the same group every single day. So we just made that an open format and I was able to modify content as needed. Also, patients, the older patients are spread across six wings, which is good because they're mingled with everybody. But it took, like a little time and creativity finding a common space and gathering them, but it worked out fine. Also, things like medication adjustments or their sleep regulation or just mood in general. Sometimes like a person could be very functioning and participative one day, but then the next day they don't want to go at all, so you just have to be flexible that way. And just knowing that group participation is voluntary even for the involuntary patients, so it required a lot of warm outreach. And then the theoretical grounding, person and environment, social learning theory and mutual aid, strength-based practices, and the NASW competencies. I think they were all met, but the ethical behavior, engaging diversity, community engagement, and group facilitation, I thought those hit competencies 1, 2, 6, and 8. Okay, next slide. Okay, and what I learned and looking forward was that wisdom goes both ways. Life transitions are universal. Flexibility is a clinical skill. Intergenerational mixing and cross-generational wisdom is powerful. Honoring autonomy is an intervention. And all that being said, sometimes it is appropriate to stick to just the 50 plus population because sometimes they want space just for that. And I did shadow the Princeton House outpatient, and they have an older adults group. So I ended up sharing this whole program with them because that might be a space where they do have the separate, just that age group therapy. So looking ahead, I'll champion intergenerational models of care that leverage cross-pollination as a clinical resource in hospice, palliative care, or private practice where lived wisdom is centered and aging is honored as a process of becoming. Okay, next. Thank you. So I just want to thank Rutgers School of Social Work, the Taub Foundation, and Princeton House. It was really fun, very worthwhile, and I think it received great feedback from the patients. Thanks. Next slide, and then it's done. Okay, thank you.
Diana, thank you so much. It's so much care and intentional thought and development in your work, and I'm just so happy to see it fully formed and excited for hearing from you post grad on what work you'll continue on with this project because I know it'll be wonderful in especially the spaces you mentioned. So thank you so much for that. Um, Kylie. I'm going to introduce Kylie Manville now, our next fellow. Thank you, Diana. And I know there was a question in the chat, but I've bookmarked it and we'll be able to uh, address it at the end of our presentations. And I'll invite Kylie to go ahead and share your presentation when you're ready for our next fellow presentation. Thank you, Kylie Manville.
Sounds great. Hi, everyone. All right, I'm going to share my screen. I'm so honored to follow the other fellows already, and Chris will be next. All right, hope you can see my slides okay. So I'm
Perfect.
Kylie. Awesome. I'm Kylie, and my project for the Taub Fellowship is entitled Supporting Response of Certified Nurse Assistants and Nurses to Residents with Behavioral and Psychological Symptoms of Dementia. So let's get into it. My practicum placement was at Parker at Landing Lane, which is a skilled nursing facility that where 50 long-term residents live. And a lot of the residents there are living with dementia-related illnesses. So I wanted to focus my project on something in that area. And I really loved my placement there. getting to know all the care partners, which is what we refer to the staff as there, and also the residents. Some of my daily duties and activities that I did there were participating in interdisciplinary meetings, care plan meetings with residents and their families. I interviewed residents when they first moved in and conducted that biopsychosocial assessment that social workers do to gather information about them, their life, and their preferences. And I would also assess their mental status and their mental health on a periodic basis. And another really fun project that I'll explain a little bit because it ties in is that I did something called All About Me posters where I made a poster for each resident that was hanging in their room that had important information about their family, their preferences, and like where they were born and raised, things like that, so that care partners would be able to know that stuff. And it was hanging on each resident's wall. So those are still up. And yeah, it was a really great experience. And Parker, I will say briefly too, they offer a lot of services to older adults. They have things from adult day services to home and community-based services, and they also offer other long-term care options aside from Landing Lane as well. So they do a lot. And I'll start again here by explaining what dementia is a little bit and what are the behavioral and psychological symptoms. So dementia is kind of a colloquial term for major neurocognitive disorder, and it can be caused by Alzheimer's disease, vascular dementia, frontotemporal dementia, different conditions. And the behavioral and psychological symptoms is also a term for all different categories of things that people might experience, which is due to the changes in the parts of the brain that mediate emotional regulation, self-awareness, and perception. So some of those categories here might be cognitive changes. So someone might experience delusions or hallucinations, or be, confused. People might have motor symptoms like pacing, physical aggression, wandering, things like that. Verbally, they might yell, call out, or have repetitive speech. Emotionally, there's a lot of different things like depression, apathy, anxiety, um, and the vegetative section that refers to like disturbances in sleep, and appetite that can also occur. So, why did I decide to do this project and how did I see the benefit? The nursing team had identified a need for some members of their team to maybe get a little more supportive training on communicating with residents with dementia, and like especially if they were confused, just some support on that. There was also like a bigger call from the interdisciplinary team to enhance the process of behavioral interventions for residents with dementia. This would be discussed a lot in our meetings, and so I thought it would be a good area to focus on. And there is a standard at Parker to provide person-centered care, and they do a lot of things to support that. There's a lot of training from the care partner orientation that everybody goes through to, ongoing continuing education. But I saw an opportunity for there to be like a highly practical, in the moment training for CNAs and nurses to reference when they're in the midst of these kind of difficult situations. And there's also research on nursing homes and training where it's been shown that staff there might benefit from more bite-sized trainings that are very focused and that they can take in the moment. Um, so the hopeful results of it that I saw were that the certified nurse assistants and the nurses would be more prepared to respond to challenging behaviors. I hope that residents will be able to receive the care that they want because what they're trying to communicate would be maybe better understood with these tools by the staff. And that psychotropic medications would kind of continue to be a last resort for managing behaviors. And I thought it would be great that the busy nursing staff would be able to sprinkle this learning in throughout their day and engage with the materials that I would make as needed. Yeah, so this is a little bit of a breakdown of how I went about this process. Like I said, I started with hearing from the interdisciplinary team, and then I wanted to get a better idea of it from the nursing team perspective, especially from the certified nurse assistants. So I developed a survey to understand the issue, and it was really important for me to start there in like a collaborative way, with all of their input. I thought that it would make the solutions and the tools that I offered, more applicable and just make any changes that I was hoping for more lasting with the buy-in at the beginning. And then from there, after I developed the survey, I administered it, I analyzed those results, and I created a micro-learning tool with what I learned from that. What was also really cool throughout the process, from the beginning to the end, I met with different researchers and professionals in the field to understand like current advancements in evidence-based practice in this area, read a lot of research, and kind of ended up compiling a lot of that in the final tool. But it was cool to hear from a lot of different people that are working in this field right now, what they have seen is working in the moment. So that was really awesome. And this next slide shows a little bit of how the survey looked. So I used Qualtrics to make this survey, which I had access to through Rutgers. That's why there's the Rutgers banner there. And this is one example of just how a question looked. All the questions were multiple choice. There was only 10 questions. I wanted to be pretty brief so that the nurses and CNAs would be able to finish it pretty quickly, and it didn't require them to sit down and take a lot of time. I gave a disclaimer in the beginning of the project, in the beginning of the survey, I mean, that it's for an educational project, just so that people wouldn't be pressured to think that it was the answers that they gave were having any reflection on their work or like how they were evaluated. So I also made it anonymous as well for that reason. And I asked a lot of different things. I asked like demographic questions about how long they've worked at Landing Lane, if this is their first job in this kind of position, what other training they've received, like this question here, and what's their experience working with people with dementia-related illnesses. Um, so then these two questions were the most important ones in the survey. The first one here, it's saying, asking what scenarios that they've encountered in their work that, is in this area. So one of them, the first one, it says a resident initiates conflict, and I give an example for each one. Or resident refuses assistance with activities of daily living, which is like bathing, dressing, things like that. Just trying to get an idea with that first question of what they're experiencing in the day to day, like what scenarios are you coming across? And then the other one asks if they were to participate in a training on these topics, which area would be most interesting to them. So I gave the option of others so they could write in a different area, or they could also put none of the above. I was open to the idea that maybe people felt prepared enough and they actually don't think that they need any further training with these areas. So those are the most important questions of the survey. And the results here, it was great. I got 15 responses, which is a 27% response rate out of like the 55 nurses and CNAs that work at Landing Lane. So that was amazing. I got a range of experience levels. Some people have been a nurse or CNA for more than 10 years, some people for less than 1 year. Um, Respondents from all different shifts, which was great because there might be different challenges, in the morning compared to at night. And many people also had personal experience with dementia-related illnesses, maybe helping their family members. So that was also interesting to read. And something else I thought was cool that I also asked was I asked what brings you joy in your work with residents. It's kind of a strengths-based question just to see what people what brings them joy. It's not all difficult working with people with dementia. So a lot of people said that they love making their residents laugh or talking with them about their families, all things that are really relevant and important for then also responding to BPSDs. So that was really amazing to read. And then some of the areas that got a lot of responses were people reported that oftentimes residents would refuse assistance with activities of daily living. People would also make comments that indicate a lapse in memory, so people are confused. And then thankfully there was interest in all of the different training topics there. Like nobody put none of the above, which was awesome. And I chose to highlight the three on the left for my final microlearning tool. So the three I chose were responding to conflict, responding to residents when they're confused or disoriented, and how to readjust your care practices to meet the changing needs of a resident. So that might be necessary if someone's dementia is progressing, how you can maybe change how your normal routine was and now needs to be audited a little bit. All right. So then what I did was make this microlearning tool as I shared. I use Genially, which is a program that you can make nonlinear interactive PowerPoints. Kind of like Canva, but it has a little bit more capabilities to, yeah, just modify it, add questions, like games, little things like that. So it was really cool to learn and to use. it allowed me to kind of make a tool where the learning could be delivered in short, focused bursts, which is like the core of what microlearning is. And kind of as I explained earlier, this can be like in the moment support that expands on the in-depth training that nurses and CNAs already get and receive through their time at Parker, but kind of give them the confidence and ideas in the moment of dealing with a challenging situation. And I kind of strove to live up to this quote, um, which is that this hopefully would activate prior knowledge, like I'm saying, contextualize skills or problems in real situations connected to learners' jobs and careers so that they could immediately apply that learning. Um, yeah, and it was really cool. So what I'm actually going to do now is briefly show you guys um, what my Genially looks like. I'm going to have to stop sharing for a second and then just switch over. All right, so hopefully you should be able to see it here.
Perfect.
Okay, great. So this is what it looks like. This is the landing page. So it's really just a link that I can send out to anybody, and then they're able to open it. Like you don't need a Genially account or anything. So this is the landing page. You go there, and then I created this main menu. So these are the three categories I just discussed, and you could click on each one. It's a button. And then yeah, you can just kind of start your learning. So I'll start with communicating with a resident who is confused. Um, so this is the start, the arrows, and there's also like a home button on each page. You can return back to the home if you wanted to change topics. But I started each module with kind of questions to ask yourself, kind of getting yourself thinking about what situation you're dealing with and giving you a little ideas at the outset for how to respond. Um, and then, like I said earlier, I had made those all about me posters for each resident and landing lane, and this is a fake one that I created here. Um, and it kind of just was to explain to people why did I make those and what the relevance could be to their daily work. So I give the opportunity here for people to just review it and see what you think. And then in the next page here, I broke down like what each part could be relevant for and how it might inform how someone's behaving or how you can respond to them. So one of them that was really important for this fake example is that she was a housekeeper for most of her life and her career. So you might ask yourself, like, how do you think this could impact her daily routine and how she presents that she was a housekeeper? Like maybe she's going to be cleaning things a lot and um, yeah, how could you just respond to that if it's like maybe she's standing on her feet all day, wiping things down and cleaning things, and she's kind of in that routine? How can you redirect her away from it if she's doing it for too long? Or how can, maybe you offer her a job where she's able to do some things that she's used to? And yeah, just different preferences and reminds us how we can bring these things into the everyday life of a person. And one of the most important things is I included a lot on these posters, names of people's spouses, their family and friends, because a lot of times when someone is confused, they might, call out for somebody or, name somebody by name, and then you would know who that person is. You could be like, oh, I see for this woman, James, that's her husband. Maybe I'll ask her a little bit more about her husband because I know who that is now. So just add some context. And then I was able to ingenially also embed videos. So this one here is from Tipa Snow, and it kind of explains too how knowing something about somebody a little bit more can help you to redirect a challenging behavior. So it's really tied to that last part. And yeah, I was able to edit the video to be a little shorter, so it's getting to the core of the problem. Yeah, and then this one for this module, I also offered an example scenario of communicating with someone who's confused and also emotional. So they're confused and it's kind of distressing to them as well. And I broke it down into what parts that the care partner said could you replicate and like the flow of this conversation. How could you do the same thing? Because it's kind of a model for how to interact with somebody who's confused and also emotional. Yeah, so highlighted that. And then there's some tips. I made sure to also note here in this area that it's really important if there is someone who's, emotionally distressed for the CNA or nurse to let the social worker know, because that's part of our role to emotionally support people and also to connect them to other resources if they need help. So I definitely made sure to note that here. And yeah, just give some more tips. Um, and then this one is another really cool video about, embracing somebody's reality who's living with dementia and seeing what they think is happening. And yeah, it just shows how doing that can actually make things less distressing and less taxing for you and for the person. So yeah, and then that's the end of that module, and then you can kind of go back to the home screen and explore the other ones. So I'll stop my share again and go back to my slides. Thanks for bearing with me. All right. All right, so we should be back to the slides now. Okay. So yeah, I did encounter some challenges doing this project. It was hard at first to get survey responses. The CNAs and nurses are so busy, and also I think maybe at first I was not being as clear about what my purpose was with doing it. So I did get the opportunity to kind of create like a pitch for it to CNAs and nurses and ultimately explain that I think this will make your work a little easier and you can have these tools on hand. Sometimes in the past, maybe tools are sitting in a binder just on the neighborhood and people aren't looking at them just because it's not as accessible. So I wanted to make something like this. And yeah, that helped me to kind of get more responses and yeah, hone my explanation of what I was trying to do. And what was also a little hard was to narrow the focus for the final deliverable. I wanted to talk about all of those topics, and there was interest in more training on all of them, but I narrowed to those ones that I had learned a lot about and also that there was a lot of interest in too. Um, so yeah, I learned a lot. Going forward, I think that future interns can definitely add other modules, like I'm saying, those ones that I didn't get to touch on. And that would be probably a really cool thing to do for them as just like a little additional project to work on. And genially is there's definitely a little bit of a learning curve, but it's pretty easy to pick up on. So I think they could also, add those in. And it's able to be shared and edited that way too, which is cool. Um, I definitely was interested in getting formal feedback from the CNAs and nurses, and that would be kind of a future thing. Um, I was able to present it to a group of nurses already, and they were really excited about it. They were like, "Can you send it to us?" So there was interest there, but it would be cool to develop more formal feedback on that and see, kind of evaluate it a little further. I also see the potential to use this tool in a group setting. So kind of it could be the scaffolding for a more formal in-service or like a group activity where people could look at the one part that I just showed, say, where it's giving an example communication and they could kind of role play a similar scenario. So it could have that opportunity. And then there's also the potential that this type of project could be expanded to other departments at Landing Lane. While I was going through the process, I did hear some interest from like the dining services or at the activities department. Even environmental services was interested in just learning a little bit more because they're of course also communicating with residents all the time. So there's the opportunity to maybe expand this a little bit. It's geared more towards the CNAs and nurses, but there could be a chance to alter some of them or just provide the training and see what sticks for other departments as well. So that's exciting. And then my main takeaways from the project, I definitely gained mastery in using Qualtrics and also Genially in both of those. So that was great. I think that I would definitely use both of these programs in the future in my social work. So that was great. I got a lot of confidence also in synthesizing information and making it more digestible, like distilling the research down and making it very practical and specific, which was difficult, but it was really cool to try that. And then I also got a lot of practice in advocating for time for evaluation. Social workers can be so, bogged down with the daily tasks that we have to do, and it might be hard to take a breath and kind of evaluate what you're doing. But I think the survey also provided information to my supervisor and other social workers in nursing homes that maybe these types of trainings are needed, and the way that we do in services might need to have this additional piece to reinforce learning. So that was cool. And that is the Council on Social Work Education's Competency 9 for evaluation. Um, and yeah, I definitely got increased understanding also of what it's like to work in an interdisciplinary team with nurses, the occupational therapist, speech therapist, doctors. I learned a lot about how to honor other people's time, how to center their input, especially when I'm creating something that's for their work. Um, and I honed in a lot on like what social workers can offer and what I can offer specifically, which might be the research capability, the expertise in communication, and also behavioral health expertise and how to apply that. So that was that. Thank you so much. These are some people that were really helpful and important for the project. Some of them are joining today. Um, yeah, like Marcy Salzberg helped me a lot. Was one of those professionals I consulted. Dr. Snedeker helped me so much. Landing Lane, and also, of course, the fellows heard out my ideas as I went through this whole process. So thank you so much.
Thank you so much, Kylie. We are so grateful for your work and helping to contribute, training and dissemination through Genially, which I still struggle to say, but I appreciate you bringing me forward in our tech and in our opportunities to use these tools for good and through the training and supporting one of the largest workforces that is so incredibly important in the state as well as nationally when we're thinking about professional caregivers. So I really appreciate your work and thank you so much. And last but not least, I'd like to welcome Christopher Stanley to present. Just a gentle reminder rather. I see some questions popping up. I'm so glad that there are questions. We will address all of them at the end of the presentation. So thank you. And I would like to again invite Christopher Stanley, our final Taub Fellow, to present their work. Thank you all so much. It's really tremendous. Thank you, Chris.
Thank you, Dr. Snedeker. Hi everyone. My name is Chris Stanley, and I'm honored and delighted to tell you a little bit about my Scam Smart presentation. This past year, I have been interning at the Jewish Family and Children's Services of Greater Mercer County. It was truly a wonderful experience. It actually wrapped up this past Wednesday, and even though I'm very grateful to have a little bit of extra free time, I've been finding that I've already been kind of missing the work, which I think is a testament to what a great and supportive organization it is. During my time there, I was a clinical team member, and my primary responsibilities was that I provided therapy to a couple of individuals. I helped manage the clinical intake process, and I also put together a couple of training presentations throughout the course of the year that I led staff in. For my Taub Fellowship project, I decided to create an educational presentation entitled Scam Smart. And as you can probably tell by the title, this presentation was all about helping folks feel empowered to protect themselves from common scams and fraud in today's world. During the course of the hour-long presentation, we went over common scams. We also talked about tactics that scammers will often use in order to gain access to your sensitive personal information or your financial assets. We talked about some of the red flags that people can be on the lookout when trying to spot a potential scam. We talked about some preventative steps that people can take beforehand to make it more likely that they will not be the victims of that kind of financial exploitation. And we also talked about what we can do and who we can report to if we suspect that we have been the victim of a scam. And kind of in the midst of this educational presentation, I would also kind of create scenarios based off of the information that we had been learning and invite participants to think about how they could respond in that scenario based off of the information that they had just learned. So why focus on scam prevention? And in kind of answering this question, I want to have kind of share two different reasons. The first is that there was a lot of professional reasons to do so. During my time at Jewish Family and Children's Services, there were numerous instances, both in our clinical team, but also our social services team, our food pantry team, where staff would report situations where clients had been the victims of scam and financial fraud. And this aligned with my experiences actually at my previous field practicum at the Center for Modern Aging in Princeton. And it was a very similar experience there. There were a lot of individuals who I encountered who themselves had either been the victims of scam or knew a loved one who had been a victim of a scam, or were just generally speaking anxious and nervous about, possibly being scammed. The other professional reason why I decided to go with this is that this is a growing social problem that is impacting all demographics. I want to just share some information. It's not actually on the slide. Um, but in 2024, the Federal Trade Commission did a report, and they found that American consumers in just that year reported losing $12.5 billion from scam and fraud. That was a 25% increase from the previous year. Kind of the thought is that that increase has actually in part been caused by the emergence of AI technologies, which is making scams look even more convincing and hard to spot. And what's really troubling about that number is that the reality is that that's probably vastly underreported. Many times when individuals are the victims of scam, they either don't know who to report that information to, or they keep it to themselves because they feel embarrassed and ashamed about it. And even though this is a societal problem that is impacting all demographics, it is important to recognize that older adults are often targeted due to their accumulated savings, their greater home equity, and the prevalent stereotype that older adults don't know how to use technology safely. Um, so those are kind of the personal reasons why I decided to go with this project, or the professional reasons. When it comes to personal reasons, I know that my paternal grandparents, who I was, were very close to before they passed away, they had been the victim of numerous scams over the years, and I saw just kind of firsthand how much emotional damage that did to them, and how confusing those experiences were for them. And I also know that one of those scammers actually tried using my identity, that they tried to impersonate me to gain access to my grandparents' assets and personal information. And so this was something that was just kind of near and dear to my own heart, just because of seeing how scams and fraud had affected my grandparents. So, in preparing for this presentation, I had to do a lot of personal learning. Certainly, I knew a little bit about scams and common forms of financial fraud, but I also, entered this process recognizing that I really didn't know a whole lot about it. So, I visited a lot of popular websites. I read some popular books on the subject that were really helpful. And so, the first step was just trying to gather information that I knew was going to be accurate, relevant, and well communicated. I know that some of those resources that I found particularly important were the Federal Trade Commission, scamteach.com, AARP Fraud Watch Network, Stay Safe Online. And the two books that I found to be the most helpful resources were Safe and Secure, A Senior's Guide to Avoiding Scams, and Cybersecurity for Seniors Made Easy. So once I gathered all of that information, and there was a lot because there are so many different ways and forms that scams can take, I began to have some conversations with JFCS staff, family, and friends about this subject in order to determine which information should be included in my presentation and which information to exclude. Because the reality is that if I had tried to cover everything there is to possibly know about scams and financial fraud, it would have been a 3-hour presentation, and nobody wants that. And once I put together all that presentation or all that information, I determined that I was going to present this information in 3 ways. One of them was going to be an interactive webinar. I also decided to do an in-person presentation at a local library. And finally, I decided to personally record the presentation on a video that could be posted on JFCS's YouTube page, so that, after I left, that resource would still be there and it could still be a resource that the staff pointed clients to. So reflecting on how the presentations went, the webinar had about 10 participants, and it was a really great time. There was a lot of active involvement, and there was clear enthusiasm for the topic. A lot of good back and forth dialogue. When it came to the in-presentation or the in-person presentation at the library, unfortunately, no one showed up, which was obviously a little disappointing. But the online recording went very well, and as I said, JFCS has posted that on their online YouTube page. So I feel good about the fact that that information is always a resource that the staff have that they can certainly point clients towards. And when it comes to kind of lessons that I learned from this experience, one of the lessons that I learned is that knowledge is power because uncertainty often fuels anxiety. In talking to a lot of the participants in the webinar, something that I kind of picked up on is that a lot of these individuals have had loved ones or they themselves have been the victims of scam and fraud. But in the aftermath of those experiences, they weren't necessarily sure what exactly had happened or how it is that these individuals gained access to their sensitive information or even what they should have done differently. And I think that based off of that, that kind of fueled an underlying uncertainty, which just made people feel anxious. And so I think it was very helpful for folks to just learn the basic information. And I could just tell based off of people's body language, but even, their explicit statements that people found this information to be empowering. I also think, based off of the feedback that people shared, that understanding common scam tactics, especially emotional manipulation and the effective use of technology, I think one of the advantages of sharing those tactics with people is that I think it very much lessens shame for victims of fraud. I think that when people have been the victims of scams, sometimes there can be unhelpful messages that they internalized, like I'm gullible, or I should have been smarter, I'm too trustworthy. But I think when people realized just how clever scammers can sometimes be in utilizing some of these tactics, I think it kind of lessens shame, which increases the likelihood that, should people find themselves the victim of scam, that they will feel more comfortable reporting that information. Um, when it comes to additional lessons learned, I think one of the lessons that I learned from this is that there's very much kind of some important nuance that we need to use when thinking about scams, especially as it relates to older adults. I do think it is very important to recognize that, one of the stereotypes is that scams, only affect older adults. And the truth is that it affects people of all ages. As I said, that this is clearly an age-inclusive problem. Um, but I also do think it is important to recognize that some older adults do face increased risk due to factors like social isolation, cognitive changes, or sometimes even generational norms about trusting authority. Though it's important again to realize that these factors can impact, people at any stage of life. Um, Another key takeaway that I had is that scams are an increasing social issue, and that unfortunately, this social problem is only going to get worse with the increased prevalence and sophistication of AI technology. This is not something that's getting better. If anything, it's getting worse. And I think a lot of folks who focus on cybersecurity are very much kind of ringing the alarm bell that this is probably going to be a worse problem moving forward. And then the final takeaway I had, and this wasn't so much just about scams or financial fraud in general, but just really more so to do with the role of social workers, is I really do think that there's an opportunity for social workers to be more involved in providing quality education to the wider public about a range of topics that are relevant for people's lives. I personally found it very empowering to be able to share this information with other people. And in reflecting on the other side of it, it occurred to me that there are so many topics that I think people in the wider population would greatly benefit in just hearing the perspective of social workers. I think that we have a lot to offer our wider community when it comes to educating about important issues that impact people's real lives. And then just finally, I just want to share a note of gratitude for Dr. Snedeker and my Taub Fellows. I know that our kind of monthly check-ins were a valuable part of this experience for me, and I enjoyed brainstorming with you all and also learning from you all. I will say that if there's any students who are listening in on this presentation. And if you're considering possibly joining or applying to the Taub Fellowship for next year, I would certainly encourage you to do so. It's been a wonderful experience, and I think that a large reason for that has to do with Dr. Snedeker and her leadership, as well as my awesome peers who have been part of this process. I also want to just thank the leadership of Jewish Family and Children's Services. They were fantastic advocates of just my work throughout the process. They were very supportive, great dialogue partners. So, I'm not the first student who has gone through the Taub Fellowship in that organization, and I could definitely tell that there's a real culture of just supporting the students and the work that they're doing. And then I just want to finally thank the Taub Foundation just for your generosity in supporting the next generation of geriatric social workers. As a student who is about to graduate, your organization has certainly made a positive difference in my life, and for that, I am incredibly grateful. So that is the end of my presentation.
Thank you so much, Chris. And thank you to all the fantastic fellows for their presentations. Just a moment of gratitude for you all and the Taub Foundation as well. And I'll invite Julia Stumbos from the Taub Foundation to provide us with an opportunity soon to hear reflection. But yes, I appreciate the opportunity. It's always a really big joy to work with students and to help mentor them through their projects. And I think we can all agree that the fellows this year did tremendous work in impacting so many different unfortunate concerns that still impact all age groups, but particularly with a focus on working with older people, which is really exciting and again, tremendous. So at this point, we can open it up to questions for the fellows. If there are questions, I do feel that there were, and uh, you can take yourself off mute. I think Sarah had some questions. If you feel comfortable, Sarah, taking, just sharing them. And yeah, we can revisit the chat as well if there are any questions.
Hi, I just wanted to thank all the fellows for their work and for sharing these presentations. It was fabulous to hear all of the different ways you've been plugging into these issues and considering them. Um, Diana, I was wondering, I was really struck by your tiered social engagement model, and could see it applying to so many different settings and being a really useful, framing to share with folks. But I did notice there was such a big jump between the yellow and the red, and I was wondering how you experienced that in application and whether people ended up filling in more incremental social engagement in between those two stages.
Sure, that's such a great question. And you got me thinking. I was looking at that chat question of ways we can address this even more. But yeah, so because we tend to maybe only see people a few times, we quite haven't quite gotten to that the red zone was like the more like family reunions, stress of maybe a big business convention or something like that. So at Princeton House, we focus on the little small wins, but at the same time, that is an issue. In other groups, I do a lot of dual diagnosis groups, and that comes up all the time when we're talking about support networks. So that could almost be its own session because people talk about how hard it is to go to events and their substances and like do they change their whole friend base or how do they cope with that? So I think what you brought up is so good, and my idea for this is to like yeah, either talk about it kind of like when we meet individually with people and set some goals, but also I got a chance to shadow the outpatient one day, which was so valuable because I ended up sharing this program with them. And I think that's a much longer term. Sometimes they're there, I think 3 months. And that would be a great way to measure and have goals to build up to that because they end up going home they go there for like a few hours a day by the end. And so they can really put it into practice in real life. So thanks so much for bringing that up.
Thank you. Thank you, Sarah. Were there any other questions for our fellows?
Think sorry to jump in, but I think Sarah had asked a question also of me that I can briefly
Oh,
respond to. And it's a good question asking about the areas in which for my two questions that I showed you guys that were care partners interested in receiving more training related to the scenarios that they most often encountered, like was it a positive kind of correlation there? And then you had me I was looking back at my responses and I noticed that like for something like refusing medication or food and water, that was really like highly reported as something that people experience in their work on the day to day, but they didn't express interest in being trained on that. Maybe because they feel like it's maybe more straightforward or they have it handled. But then other things were commonly encountered, and then they also requested training, something like responding to conflict. So I think maybe it depends on what type of scenario it was, or sometimes you do it all the time and so you feel practice. So I think there was both. But thank you for the question.
thank you so much. Thank you, Sarah. Kathy, you had a question?
Hey there. So actually, I have two. For Kylie, can you send me your findings? I would like to share them with the Essential Job, Essential Care Coalition in New Jersey. One of the things they were doing was outreach to direct care workers, including CNAs, and I think that would be really helpful for them to see. So if you want to share it, I can pass it on and do an introduction.
Yeah.
I had a question for Diana, which is something that I didn't realize before, because we talk a lot about the the mental and physical impact of social isolation. But as you were talking, the group therapy and fighting social isolation to me were so intertwined that I I'm trying to think of what my question is. Like it seems like even before the therapy starts, breaking down that social isolation had a positive benefit. What was a form of therapy itself?
Yeah, I'm trying to think of how to answer that. There's one sheet I formed that almost looked like a bullseye, and it's like it's for them to visualize a picture of like where they're at now. So like their inner circle is like I don't know if this answers the question, but the people like they can really trust, and then the that next circle is more like I guess maybe mezzo, like their neighborhood or something like that, and then the outer circle is like just the bigger community in general, and just like writing down and seeing like kind of like I guess what I was saying, it's like more about support. And so uh yeah, I think it's like it is a good point to figure out like when do you like figure out individually what they need versus addressing it in the group, or maybe taking feedback in the group and noticing, oh, this person seems like they have more problems with isolation, so maybe we should bring that up to their social worker and they can address it individually too. Does that make sense?
Thank you. Thank you, Kathy, for that great question and for all of the conversation in the chat. I want to thank again the fellows for their work and invite Julia Stonebos to provide some closing remarks on behalf of the Tau Foundation to the students and to everyone joining to essentially close us out for the morning. Thank you so much, Julia.
Thank you, Lauren. It's an honor to be here. Thank you for inviting me. I always find this event so inspiring, so interesting, educational, many, many things. So I appreciate being invited. And I do represent the trustees and staff of the foundation, and in congratulating all of you on completing your certificate program. That this is the time of year to celebrate, and we're with you, and your leadership projects have been amazing. the foundation gladly invests in the work that you're doing. And we support your leadership and your professional development and the new ways that you're thinking about aging. So we're grateful for this extraordinary guidance from your professors and your administrators, Dr. Lauren Snedeker, Dr. Emily Greenfield, Dean Leibowitz is here. Nice to see you, and other instructors and supervisors that helped you along the path. I'm sure many of them added to all of the accomplishments of your year. And we just like to say to you that we need more good people like yourselves to be well trained, to focus on achievable solutions, that you're really doing that. And you're poised to do the work, to be creative, to bring your kind spirits to the everyday challenges as we, as a society, face longer lives. And we congratulate you for finishing your degrees and for bringing curiosity and creativity and goodwill to the field of aging. And I personally hope you find the path that feels right for you and that that path includes a career in aging. We need you. And thank you, Peggy and Diana and Kylie and Chris, for your contributions. It was amazing to me to hear that many of you created your own guides and tools, and all of that is so helpful to the field. We appreciate the work you put into it, the thought, the intentionality, and hope that you choose the field of aging and any one of its many aspects in your future. So thank you. Thank you for inviting me, and good luck with your futures.
Thank you. Thank you all so much. Thank you, Julia, to the Taub Fellows. I want to say a special thank you to Natalie Pope, who is our senior program coordinator at the Hub for Aging Collaboration, and just a tremendous support in the Zooming, in the coordinating, amazing attention to detail, and just like sort of like my emotional support with doing events. So I just want to thank that, and to Emily, Dr. Emily Greenfield, our hub director, who's here as well, just cheering all of the students on, and for the rest of the community that are part of the Aging and Health Certificate program. It's just really my favorite day, along with convocation. So thank you all so much. We can probably end here. We'll just, keep the Zoom space open for a few moments. But again, a special congratulations to all the fellows. Tremendous, tremendous job. And thank you all so much. We hope to stay in touch with you. Please stay in touch with me and each other. And congratulations. Thank you so much again for being here today. Thank you to Dean Leibowitz as well for providing us that support and our extra cheering on as well. Thank you.
Absolutely a pleasure. Thank you.
Thanks so much. Thanks, everybody.